Okay, thank you for the opportunity to be here again. I learned a great deal by being here, and so I'm very appreciative. All of my disclosures are on the AAOS website, but generally you should know that I do have a lot of conflicts of interest in what I'm showing you, and I'm very biased. So, actually, hearing the meeting as it's been going on, I reshaped my talk a little bit so that I could address a number of issues that have been discussed here, but basically, the issue is that we have a biological problem, and somehow why not have a biological solution? So what we find out in the knee, for instance, if somebody has a biological problem, we're going to treat this type of problem with a rather large incision and then put in metal and plastic, and now we have a bionic solution. And although they're satisfactory in most situations, I don't think that's exactly where we should be going. So over time, I've had a journey from traditional medicine to alternative medicine. And in my training, this is the way I was told that we needed to treat people that had some arthritic change on the inside of their knee. And of course, you can see that the treatment was far worse than the condition. And this was called a pretty procedure, which really wasn't very pretty. So then we knew for certain that cartilage could not repair. That was not too long ago. But that idea is slowly going away. So the more famous the person that was certain that of this edict that seemed to change over time. So what we knew for sure was not necessarily true. But then when arthroscopy came along, it was interesting that the group that was most against it in orthopedic surgery was the sports medicine doctors of the day. And of course you can see that's changed. And they would argue, why wouldn't you allow us to open the door rather than look through a keyhole? And I used to tell them that, well, gentlemen, we could go out on the street and ask people what they'd like to have done. And so here we see the arguments are long gone. This is past history. You can see the incision from opening the door, and you can see the incisions that happened, the minimal trauma from looking arthroscopically through a keyhole. So what I wanted to do, and I've reshaped this somewhat because of having the opportunity to sit at the whole meeting, I wanted to discuss understanding the pathology behind end-stage osteoarthritis, understanding the biological response, the fact that we need ingredients of the matrix cells. You'll be amazed at what I'm going to show you about unloading the joint, and then we'll talk about optimizing the synovial joint environment, and then finally a wound healing enhancer. And if I have time, I'll deal with selling your intellectual property and how you deal with the battlefield of change, which you're in the middle of. And if I don't get to that in the interest of everybody's time, I've written that up already at the end of what I wrote for you. So let's look at the end-stage osteoarthritic sclerotic lesion. And the natural history is that the cartilage gets worn off, and there are dead osteomes on the surface, but the blood supply is starting to come up near the surface, as you can see by those fissures. And here you can see the blood supply is actually right at the surface, even though there was an injury and wore the cartilage all off. And so if we look at the gross anatomy unstained, we'll see that it just looks like a shiny mirror-looking surface, but if we put methylene blue on it, we'll see there's a number of pits. And we published this in the Knee Journal. A closer look shows that what we have there is aggregates of cartilage and multiple pits. And the pits are of three natures: bone fragmentation, cartilage aggregate erosion, and vascular rupture. There is one of the fissures that occur from bone origin. And here's a cartilage lesion, that a regrowth that has eroded. And the other one would be vascular, that didn't show up, sorry, and the other one would be where blood vessels ruptured. So those three pits all serve as a home for cellular treatment. So if you can think about that, that is an opportunity. But this is what's probably going to be important for you to clearly understand, and that is when we look at these end-stage sclerotic lesions, there already are cartilage bundles, or we call them cartilaginous aggregates, that are moving up towards the surface. And these probably happen. Here's the natural history of a patient who came who had an end-stage lesion. Arthroscopically, we could see that it bled, and we can see the vessel at the surface and the bleeding that occurred there. These may be, and I can't see this longitudinally, may be one of the reasons there are aggregates. So we know one of the basic factors of healing is certainly, as you just learned, bleeding and blood clot formation. And what was interesting, that orthopedic surgeons doing arthroscopy didn't think that a blood clot formed, because they looked in with the scope, distended the joint, washed it all out, and when they looked, there was no bleeding. So what I did, I looked at 22 consecutive cases after I took the arthroscope out, waited 5 to 7 minutes, looked back in, washed it out, and every place there is a laceration or any incision, a blood clot forms on cartilage or on meniscus or on synovial. And for some reason, the orthopedic surgeons were blind to the idea that a blood clot did work in the knee as well. And so what we have is an articular cartilage environment. This is the type of clot you would see in a partial thickness lesion. And so this can be a small depth, it could be any depth, it could be full depth. This one is of a traumatic origin. If they have shoulders on them so that you can house and hold the clot, there'll be articular cartilage healing by subsequent biopsy. But what usually happens is the patient wants to get going right away, walks the blood clot off. So I had the idea a long time ago of arthroscopic abrasion arthroplasty, where it was a superficial abrasion like dermabrasion and exposed the superficial vessels. And then what happened after that was that there was a regeneration of the cartilage on the surface if this joint had been protected. You can see on the left lower side of the histology, you can see normal cartilage, and then you can see the fibrocartilage to the right, which is adhered perfectly to it. And of these patients, about half had a wider joint space at the end of 2 years, not all. But what we learned over time was how people could get a bad result. And so they would pick the wrong patient. Somebody wanted a total knee, someone wants to be normal, or workers' comp, or you can't meet their expectations, or they wanted to run a marathon. And you can get a bad result if you pick an unstable knee, an ankylosing knee, or one with severe malalignment. And the other way that's most common is that you'll cut too deep and you'll make a severe injury and the patient will hurt more, and then you forget to treat the mechanical problems, the misalignment, or you forget to debride other soft tissue problems. Or finally, let the patient walk on it right away. They'll walk the blood clot off and there won't be any healing. So normally these patients had to be protected, just as you would protect an incision on the arm or elbow or hand, for a number of weeks, and then gradual resumption. So then after this, microfracture became very, very popular. Stedman and Rodke, both friends of mine. But however, over the years now, it's fallen out of favor, and Jack Burt last year and others have now have pointed out the failures of microfracture and some of the different problems that it has caused. And so people have turned back, interestingly enough, to abrasion arthroplasty. Now I want to share with you what long-term follow-ups, and I think if you go 13 to 21 years should be a satisfactory long-term follow-up. And I published both of these in the Cartilage journal. And this is the type of thing we did. We had lesions that were large-size articular cartilage defects, of which we debrided arthroscopically, and then we used autogenous bone from the tibial metaphysis proximal, put it in with a super diameter syringe, packed it down in these patients, the ones we did arthroscopically. We allowed a blood clot to form, and then the patients had to protect that for about 8 weeks. And then we had the opportunity to do second looks, and this one happens to be 2 years later, of which there's the second look. A patient was completely asymptomatic, but granted a second look. Here is the core biopsy of this patient, and it shows that there's still soft articular tissue but bone beneath. So the healing principles in this was we removed the dead tissue, placed a matrix of cancellous bone. We had bone marrow, quote-unquote, stem cells. We had blood and blood clot, and then we protected the joint. Here's a patient that had a huge defect. I got severely criticized for doing him because he had already had leukemia, and with leukemia treatment had major loss of articular surface and large defects of his condyle. Over to the right, you see his flexion of his left knee at 13 years, extension of the right knee. And here you see flexion of the right knee and extension of the left knee at 17 years, follow-up on that knee. So I showed that these autogenous bone grafts, which meet all the criteria necessary for the regeneration of an articular surface, works even in a very, very large lesion with long-term follow-ups. Now I'd like to show you something that has come across my attention recently, and this is truly amazing to me. Although I knew that if you did an osteotomy of the hip, and the before on the left and the after on the right, if you change the angulation, there'd be a small joint space would occur. And then Coventry showed that if you did an osteotomy on the tibia, took a piece of bone out and realigned, that there would be a wider joint space on the medial compartment. And then there's work done that was done arthroscopically before and after osteotomy to show huge lesions in the knee journal and how it was healed afterwards. So I'm kind of surprised that they did two big open operations to get it. It was nice of them to be able to show us that. Then research was done that showed that arthroscopically, here's a bone-on-bone in the joint, osteotomy, and then subsequently regeneration of the cartilage. So only unloading that medial compartment or the hip did this. But here's the one that really got my attention. Guyton and Brand from Iowa saw two patients, came in, had a total hip on one side, and were to come back in 3 months for the total hip on the other side. And when they came back in 3 months, they said, I don't want it, I feel just fine. And so they were not given any instruction on how to protect the hip. They weren't given any ambulatory aids, and they came back. And so this first patient, 1967, that's when the doctor wanted to do the total hip. And finally in 1978, they did the total hip. And there's what's happened with no instruction. And how did the patient do this? Well, they spontaneously unloaded this hip because they had a total hip on the other side that didn't hurt. So every time they got out of a chair, they did it with their total hip side, protected this. They always watched and did it that way. And so then this one is even more amazing to me, 1994 to 2001. No treatment on this patient, no instruction, no medication, no surgery, no stem cells, and the patient spontaneously unloaded from 1994 to 2001. And look how not only did their joint surface reform, but also the bone remolded, which is absolutely astounding to me. But I think it's one of the greatest two case reports that show the benefit of unloading, which is so often ignored in whatever treatments we're giving. So here's these people, no instruction, no ambulatory aid, no physical therapy, no medication, no injections, and no surgery. Now, they subsequently had surgery. I don't know if the doctor just wanted the specimen or not. What? There was what?
It's called Obamacare.
Yeah, okay. So what happened was that they were able to show the specimens and normal articular cartilage, and you can look up their paper as there isn't time to go through every detail. So why could this possibly happen? Well, in 86 in the textbook I wrote, I showed these cartilaginous aggregates on the surface. And so these cartilaginous aggregates have the opportunity to regrowth cartilage on the surface. And we showed that they had, in the subsequent paper, that they were positive SAPHO, normal morphology, had type 2 collagen, small muscle actin. And so what we're seeing is basically a attempt on the normal natural history to heal this. So what else was there evidences in the literature? Well, Milgram reported 535 total hip specimens, which were people who had a painful hip. So they obviously were kind of unloading it. And what he showed was that the surfaces were completely getting regenerated. Even though they came to a total hip, they were completely regenerated by these cartilaginous aggregates coming up on the surface. So then there was a paper that even supported this more, and that was arthroscopically before and after high tibial osteotomy. The one group had partial thickness lesions, and the other group had bone-on-bone. And only the ones that had bone-on-bone regenerated. The partial thickness lesions did not regenerate any cartilage to biopsy. So what we have to do here, and the other aspect, no matter what treatment you're giving, we've got to optimize the physical environment by unloading the joint post-operatively. So in my view, the common denominator of all cartilage treatment methods, even the non-treatment method, is the unloading of the joint, generally 4 to 8 weeks. So then I took a look at what about wedged insoles? Could they possibly unload the joint? Very controversial in the literature, but at Scripps in California, they had 4 patients who had an instrumented total knee that could measure the peak axial loads when a patient walked. And we showed that with a 5-degree wedge insole, that worked. Why is there controversy in the literature? Well, no one in the literature tumbled to the fact that you've got to have subtalar motion and you've got to have a compliant medial collateral ligament. Because if you can't have subtalar motion the way I showed here on the left side, for either varus or valgus, And you have to sit together and have your knees together, straighten them out, and if you can hold your knees together, then the medial structures are compliant. No subtalar motion, no compliance. It wouldn't matter what the wedge did. The wedge cannot be powerful enough to overcome those structures. So there was a potential now, in my view, for either the non-operative treatment, or if you're going to have a meniscectomy, meniscal repair, cartilage repair, or post-osteotomy, or any cell-type treatment, that unloading the joint by this method would be optimal. Now let's take a look at phytochemicals. This is something I've been working on for about more than 10 years. And what it comes up with, we have a way to optimize the biochemical environment factor in joint injury and disease. Now, what I'm going to talk about is a reagent called Protocateuic Acid. And it is a phase 1 metabolite that comes from what's known as anthocyanins. And anthocyanins are the dyes that are in blueberries, cherries, and other plant material. And if you look this up, you'll see that it has a powerful antioxidant, but it has antibiotic effect, anabolic effect, anti-inflammatory, antimitotic, and also can be hypoglycemic. Rather amazing what this does. And I was granted a patent in 2012 for the injection of these, how it would alter articular cartilage and affect the joint. And then recently I was granted another patent on the fact that it is also a broad spectrum antibiotic in a different way, and that it also would promote wound healing by optimizing the local growth hormones. So now I want to turn where I have a patent in on the optimization of synovial fluid. That hasn't, I'm still waiting for my first office action on that. And that started about 30 years ago when I was asked to help on a human trial with a company called Chiron in Northern California. And they used intra-articular recombinant IGF-1. And what we saw was there was sealing of the lacerations. These were humans who were going to have a total joint in 13 weeks. And we were able to go in arthroscopically, create the lesions, and then get the histology. And we saw that with IGF-1 in a human, which we already knew in animals, that it could have a beneficial healing effect. So that just kind of laid silent for me until about 10 years ago. I saw that a lab in Michigan State University, that they put insulin, they put the anthocyanins and anthocyanidins on rat islet cells, and it made insulin. So then I raised the question, are there other places in the body where there are natural things that if we put anthocyanins on them, could we possibly have them make insulin? So that's when I went to think about going back. They're powerful antioxidants, and let me give you a little background. There's abundant literature. Most of the work had been done with primitive extracts or compounds, and all of the metabolism is known and published, where it goes into your body, how it comes out of your body, where it lands in your body, and how long it stays there. So unlike most drugs, if you're going to be worried about what's going to happen, the literature is filled with this. So then I went back to Scripps and I said, let's find out what can happen if we put it on human synovial explants that came from total joint patients. And what we found out is it turned the gene on in the human synovium for IGF-1 and increased the IGF-1 fluid in the culture medium. So it kind of supported my hypothesis. There must be other tissues, well, there are more than just synovium, but that will benefit from this. So if we look at osteoarthritis, we have a number of causes, and the pathological nature is, of course, it's degenerative, and there's a battle between the antibiotic and the catabolic factors. But one of the other present understandings is that it really has a major inflammatory component. So this you have to know, that the anthocyanins and anthocyanins are affected by pH change. So if you put them in the human body, their acidic pH is 7, they very quickly metabolize, or also quickly metabolize in cell fluid, so that within 24 hours in cell culture, it's protocateuic acid. If you take it in your body by mouth, they've carbon labeled, they find out that every 74% is protocateuic acid in your bloodstream shortly after you take anthocyanins or these fruits. Now, you couldn't eat enough blueberries to get a dose of it, but if you take it in like 500 milligrams, you'll know that very rapidly it's in the bloodstream, and then it goes down to phase 1 and phase 2 metabolites through your body. So what I started working with was not extracts where there'd be maybe 500 different things you didn't know what they were. I isolated it down to cyanidin 3-glucoside, which was available and economically available, and also the main metabolite, protocateuic acid. And so the problem with cyanidin 3-glucoside that if you were going to give 500 milligrams a day, it would only cost $77,500 a day to take the dose, so that was somewhat impractical. And even the government might support it, but impractical, expensive. So I worked with protocateuic acid in a 35% form, and that would be about 50 cents, but down to 12 cents if we used the cost of goods for protocateuic acid. So then I did an animal study, and I had done the injection, and I showed that it happened. I could change the chemistry, and I could have the synovium make IGF-1 by injection. But then it occurred to me, well, why wouldn't you take it by a pill? Because if you can get it in the bloodstream, we're just as close to the blood vessels coming this way as we would by putting it on topically. And so then I did the rabbits this way, and I'll just report the oral ones, but the ones by intra-articular injection were the same. So with the vessels close to the surface, it was practical, less expensive, and it was closer to a clinical future because now it can be a nutraceutical. And so what we did was we thought that let's determine if it, taken orally, can change the chemistry of a surgically induced osteoarthritic joint. And my hypothesis was that it would favorably alter the anabolic-catabolic balance, and maybe there'd be a positive effect on articular cartilage. A little bit confusing on this slide, maybe, but on the left is prophylactic in black, and on the right, therapeutic in the green. The prophylactics were started right away on the day of surgery, and I gave both reagents, cyanidin 3-glucoside and protocateuic acid. On the right side, the therapeutic group, there were 6 in each group, bilateral knees on each side, and we waited 6 weeks and then had only 4 weeks of treatment, or took it out to 10 weeks. And this is what we did. We severely disrupted the joint, cut the tibial collateral, took out the medial meniscus, cut the ACL, and I was curious whether this would heal a laceration. And so a laceration was made on the lateral femoral condyle. Now here's what those joints look like at necropsy. So I wanted to make sure you saw we were making the worst osteoarthritis you could possibly make because I wanted to get the most synovial fluid I possibly could. So that part I accomplished. So we did a multitude of biomarkers. Remember, the prophylactics was 6 weeks, the therapeutic were 10 weeks. So we first looked at inflammation, and on the prophylactic side, we saw that C-reactive protein was decreased by both. Instead of being 8.8, it was decreased with both reagents, the parent cyanidin 3-glucoside and the metabolite. But not so on the deferred reason, and so that could have been they only had it for 4 weeks as compared to 6 weeks, even though it was a delayed time. So I don't have the exact answer. I just know that it would work prophylactically. If we looked at inflammation, and this you can look at slides on your own, I won't go every one in the interest of a late afternoon time, but prophylactically we decreased the white blood count in all groups. In therapeutic, the same thing happened. And we also, in both groups, decreased the lymphocytes in both groups, both therapeutic and prophylactic, and for both reagents. And then the macrophages were decreased very slightly in all groups. And the MMP3 gene in the synovium was decreased. And the MMP3 in the synovium was decreased. So not only the gene, but the amount. And lubricin was increased in the synovium. And in the joint, in the synovium, the IL-6 cytokine was decreased in all groups. And the TNF-alpha was decreased in all groups, both prophylactic, therapeutic, and for both reagents. But I had everything wasn't perfect. I had a lot of inconsistent results that were with my expectations, or one that weren't absolutely consistent across the board. So platelet-derived growth factor was decreased in all groups, and TIMP1 in the synovium was up and down and not consistent, had a mixed effect. And VEGF in the synovium was increased. I thought it should have been, if I was predicting, I was thinking it'd be lower. And the synovium IL-1B was up in some and down in others, not consistent. and 5 in the synovium was up in some and down, so again, only decreased in the therapeutic. So I was learning that just everything isn't perfect, and the rest I'll carefully go through now. What about, here's the bottom line, what about the results in the synovial fluid? I just talked about the synovium, how it was altered. Had the positive results that I decreased IL, it decreased IL-1 beta in both reagents and in both groups. MMP1 is in synovial fluid, was decreased in both groups. MMP13 decreased in all groups. And then the beneficial cytokine IL-4 was increased compared to the control in both groups, and the same thing for IL-10. So I was, having seen that I was decreasing the negative cytokines and increasing the anabolic cytokines with this oral medication. Again, I had inconsistent results, which I won't take time to try to analyze every one, so some were down, some were up in the synovial fluid. And in the interest of time, I will go to the cartilage. That's just the bottom line. So in the cartilage, we found out that it was both chondronutritive and chondroprotective to the cartilage. So you see the control on the left with the SAPHO, and you see a treated SAPHO on the right. Now, the lesion, remember, was the medial compartment. I did a laceration in the lateral compartment. These are specimens from the patella, which there wasn't any direct disruption of except during the arthrotomy. And so what we saw with International Cartilage Research Society scoring, all groups were enhanced. So the surface was enhanced, the matrix was enhanced, the cell distribution was enhanced, and the subchondral bone was enhanced in all groups. There was unchanged in cell viability, meaning there wasn't any degradation of it or any major increase, because remember, it stayed pretty normal. And then immunohistochemical scoring, we saw that there was increased gene expression in the articular cartilage in all treatment groups with both reagents. And lubricin was, by the same method, was shown increased in all groups. Here you can see a control versus the prophylactic and therapeutic, showing both increased staining of the lubricin with the cyanide 3 glucoside, and you see the increased staining of the lubricin with the protocateuic acid. And the type 2 collagen was increased as compared to the controls in all groups, all treatment groups. And then in the cartilage, the IL-1B was decreased, especially in the therapeutic groups over to the right in both reagents. And the MMP3 was decreased in all groups in the cartilage. But again, I had inconsistent results, which some are up and some are down. Each would take a little bit more explanation as necessary. But my hypothesis was confirmed in the face of severe degenerative arthritis that the oral route was effective in both treatment groups, both prophylactic and therapeutic, and with both reagents, and that there was a chondronutritive effect and a chondroprotective effect. I did not grow cartilage. I don't have all the explanations. Not every cytokine was altered. Not all dynamic chemical factors were consistent across synovial fluid, articular cartilage. But it wasn't exactly the same whether it was prophylactic or therapeutic. But in general, we're able to make a major change in that chemistry. Now, so it was chondronutritive because what we saw especially happened to lubricin, but I did tell you I made a laceration on the lateral side, and there was no laceration healing. And there isn't laceration healing for a couple reasons. One, it will not house and hold a blood clot. Number two, it's moving all the time. So there isn't much of a chance in a partial thickness laceration. If you drill hole down into bone, then I know you can get a laceration to heal, but not a partial thickness one. So on the horizon, I believe there's a food supplement pill that will optimize biochemical environment and joint injury, disease, and intervention. So no matter what, and these are the presentations that were made at this meeting, stem cells, PRP, amnion, nutrition, exercise, or lifestyle, that I believe one of the common denominators for success will be that protocateuic acid or cyanide 3 glucoside prophylactically before or after. So we can optimize the synovial joint chemistry, and there can be a therapeutic and inflammatory disease, no matter what it is, can be altered by this. Now, how are we on time? I'll go over a couple of short topics, or I can stop. It doesn't matter.
Good. Get to 5 minutes.
It won't even take 5 minutes. Okay, this is, a number of you might have an interest in intellectual property. So I have over 60 U.S. patents in medicine. I have 10 in golf. That's in the last few years. First of all, don't tell anyone your idea. And if you're going to talk to somebody that's not a business, you might have a non-disclosure agreement, but you don't need an NDA if they're a business, and I'll tell you why in a minute. The next thing you do is you do a provisional patent, and you can do it inexpensively, and this is written up in your handout, at either LegalZoom or at this website I've used from India, and they do a nice job and relatively inexpensive. And then you want to make a functional prototype or have some lab evidence, and you'll find yourself, you'll be writing a lot of what I call writing term papers, because you'll just be doing literature research and writing. Then you want to go to a utility patent. If you still want to save money, you can go to the two sources that I gave you, or you can go to a patent agent, but they have some restrictions. And if the year you have from the provisional to the utility allows you to really find out if you got something, whether you want to spend a lot of money or not. And so if you go to an attorney, you might get it done for $10,000, but if it's something chemical, you can look at $25,000 to $50,000 because of the office actions from the patent office. So they often cost between $1,200 and $5,000 to $5,000 each time they write you a letter and your lawyer responds. So you want to make sure you really got something before you carry it this far. Now, what about selling your IP? First of all, you must have a patent in hand. If you don't have a patent, don't go talk to anybody. And there'd be two ways you could do this. One, you could say, oh, I'm going to not talk to anybody. I'm going to market this myself. I personally do not think it's a good idea, because generally you will lack the following. You won't have a company, you won't have management, you won't have marketing, you will not have a sales organization, you'll not have a human resource department, and you probably won't have time. So I'd recommend, if you have a patent at hand, find somebody who will buy it. Now, remember, if you're going to a buyer, you must have a patent. Therefore, forget the NDA. You know, if you want to have a patent, forget the NDA. Now, here's what they want to know. Do you have any competitors? Have you got all the regulatory issues solved? Of course, the answer is going to be no, because you probably haven't done that. How long will it take to market this? And then what they're mainly interested in is not medicine. You need to know that. They're interested in money. And so they want to know what's the return going to be on their investment. And here's the mind of the buyer. And you should know this. They're not a buyer, they're a robber. And so they're generally going to try to find out how they can get this from you for free or for very little. And the other thing is, when you meet one of the junior men at the company, they're going to say, and I say this, I even tell them up front, I have this idea and I want you to know, I know you're dealing with the fact you don't want to lose your job over Lanny's idea. So they don't want to get into this too far, because they're interested how you can help them. Can you give them an advancement? Can you get it so they earn more money in their job? And they're also not in a hurry to spend their money. Now let's take a look at the battlefield of change that you're facing. And I would briefly tell you that when I started arthroscopy, the doctors in my town were nice enough to come and tell me that I was performing an immoral and unethical operation, doing arthroscopy. Now we know it's the most common immoral and unethical operation performed. I was blackballed by the Michigan State Medical Society for 11 years, and 5 years ago I was given the inaugural Lifetime Achievement Award when they asked me not to mention the fact that they had blackballed me years before. And I told you that the sports medicine doctors of the day were most against it, but the president and the secretary came to watch me, because the hospital by that time had built a glass wall and put bleachers in, so many people were coming. And so the president put me up for the society, the secretary seconded me, and I was blackballed and didn't get in. And so 2 years later, they asked me if I'd make a 2-hour presentation to their organization, the national meeting, which I did. And they said, well, we'd like to offer you immediate membership. I said, fine. It didn't matter that much to me. This will be helpful to all of you. So you can only be stabbed in the back if you're leading. And so a lot of you may have experienced that. But if you're working on something, you've got to know that that's a potential. But here's the road to victory, which I see this organization really has got to get more of. You've got to have evidence. You've got to have controlled series, large enough N, more than 2 years follow-up, not 3 weeks. And you can't have just a series of case reports. You've got to have a series of cases. And then the other thing I found out when I asked to visit people doing prolotherapy, but not Dean allowed me to come, but I've had other ones that wouldn't let me come and watch them. I had over 5,000 visitors come watch me do arthroscopic surgery. And what has to happen, you've got to have enough openness to allow visitors and observers, and you've got to make meeting presentations, and you've got to submit this work for publication. So you already know that you're going to have people crap on you, but even if you become famous and die, and they build a statue, the same thing will probably happen for you. Thank you.